Oh hey, I know you're busy, but do you just have 5 minutes to talk to me about the new E&M 2021 changes for outpatient office visits? Okay, great. I swear, it'll only take 5 minutes. Let's go. We still have 5 levels for office visits, but they're just based off of medical decision making. Not that you don't have to do history, not that you don't have to do exam. Document whatever history and exam that was medically pertinent that you did. But let's take a look at what changed with medical decision making. So let's start with our first level, our level 1. There is an elimination of 99201, which means there is no new patient level 1 visit. There just was low utilization, and from a medical decision making standpoint, 1 and 2 were the same. So they just got rid of 99201. We just have 99211. So 99211 is basically a patient that's coming in maybe for a blood pressure check, maybe for a weight check, something minor, because you can see here the time is minimal. There's no requirements for medical decision making level, and we have our 3 requirements for medical decision making that kind of got reworded a little bit, but it's essentially how many diagnoses are you treating, how much data are you looking at, what's the risk of the patient. And the level 1 established visit doesn't really have any hard and fast rules as far as how many diagnoses, risks, or data that you have to review or order. Next, we have our level 2 visit, and I will go over the difference of the time components at the end, but you can see here when we look at this level 2 visit, there is 99202, which is our new patient, has 15 to 29 minutes. The established patient is 10 to 19 minutes. They both have the same requirements. All the levels have the same requirements for meeting the criteria for medical decision making. So we would need 2 out of 3 of those columns in order to meet it. The number of complexity of problems, amount of data reviewed or ordered, or the risk of the patient. 2 out of those 3 in order to meet this level. So for our level 2 patient, it would be a straightforward medical decision making level, and that means it would need to be 2 out of the 3 of a 1 self-limited or minor problem. Self-limited or minor meaning the patient probably, if they hadn't received healthcare services, would have just recovered on its own. Minimal amount of data or complexity of data ordered or reviewed or analyzed, and then our risk of complications is pretty minimal as well. Next, we have our level 3 visit. Level 3 new is 30 to 44 minutes. Level 3 established is 20 to 29 minutes. Now the level of medical decision making is low, and again 2 out of the 3, so 2 out of these 3 following columns. First column would be the low number of complexity of problems addressed, which could be 2 or more of those self-limited or minor problems, or 1 stable chronic illness, or 1 acute uncomplicated illness or injury. The amount of data we would have would be limited. That means they have to meet at least one of the 2 categories here in bold. Category 1 means we would have any combination of 2 of the following: review of a prior external note from each unique source, or review of a result from each unique source, or ordering of each unique test. External means it's from an external physician, external qualified healthcare professional, or external facility or healthcare organization. Tests are any imaging, labs, psychometric, or physiological data. So for example, a whole lab panel, like if you're doing a complete metabolic panel, that counts as 1 test. The difference now is that in the past, if you ordered 3 different labs, you would only get 1 point. Now you actually get 3 points in this category for those 3 different labs. And an external provider or advanced practitioner is someone who's not in the same group practice, or they're in a different specialty or subspecialty, like a pediatric versus a pediatric gastroenterologist would be 2 difference because the peds gastro is a subspecialty. Or you could meet category 2, which is assessment requiring an independent historian. An independent historian could be a parent, guardian, surrogate, spouse, witness who provides a history in addition to the patient, because maybe the patient couldn't provide an adequate history or they needed more information. And then the risk just says it's a low risk from additional testing or treatment. Now our level 4 visits for our new patients are 45 to 59 minutes. For established is 30 to 39 minutes. It's moderate level decision making. And again, we need 2 out of the 3. So number of problems could be 1 or more chronic illnesses with an exacerbation, progression, or side effects of treatment. That includes patients who are not at their treatment goal, and it is up to the provider to determine what that treatment goal is and state if they are or are not at goal. It could also be 2 or more stable chronic illnesses, 1 undiagnosed new problem with uncertain prognosis, like a breast lump, an acute illness with systemic symptoms, or 1 acute complicated injury. Amount of data is also moderate, and that would mean that we'd have to meet 1 out of the following 3 categories. Category 1 is any test, documents, or independent historians, any combination of 3 of the following: review an external note, review a unique test, ordering of a unique test, assessment requiring an independent historian. I also want to mention at this point that one of the big things with the changes is that you cannot double dip. So if you are ordering or reviewing something, but you're billing out separately for that with a separate CPT, you get all your reimbursement in that separate CPT code. So you also don't get to use it for your evaluation and management decision-making stuff. So you can't order a test, bill out for it, and then also include it in your E&M. They're very clear about that now. Next is category 2, which is independent interpretation of tests. So an independent interpretation of a test performed by another physician or other qualified healthcare profession that you're not separately reporting. So again, not separately reporting out for that. You can, if you're just doing the independent interpretation and not separately billing for it, you can get it here. So category 3 is discussion or management of tests or interpretation. So if you're having a discussion of management or test interpretation with an external physician or other qualified healthcare professional or appropriate source, again, you're not separately reporting for that. That can count towards your category 3, and we need 1 out of 3 to meet that moderate amount of complexity of data reviewed. Or we could do our risk of complications for our 2 out of the 3 columns, and that is a moderate risk of morbidity from additional or diagnostic testing or treatment. We could be, for example, prescription drug management. Check with your Medicare administrative contractors, because mine, Novitas, says that just refilling a medication counts as prescription drug management, but that depends on your area. It could be a decision regarding a minor surgery with identified patient or procedure risk factors, decision regarding elective major surgery without risk factors, or diagnosis or treatment significantly limited by social determinants of health. Social determinants of health can be found in your ICD-10-CM book under your Z codes. There are things like homelessness, poverty, inability to afford medication. It could even be that the patient has a really stressful work schedule that doesn't allow them to do things like take their insulin on time because maybe they're a truck driver and they're driving for long periods of time. And if that social status significantly limits their treatment options, you can count that as moderate level decision making under your risk of complications. And now our level 5 patient's time-based. It has to be 60 to 74 minutes for a new, 40 to 54 minutes for an established. 2 of the 3 criteria, number of diagnoses or treatment options have to be high. So 1 or more chronic illnesses with a severe exacerbation or side effects of treatment. Make sure you put that word severe in there. So if the patient has COPD exacerbation and you want to get that level 5, it has to be a severe COPD exacerbation to count for that high complexity of problems addressed here for this criteria. Or you could have 1 acute or chronic illness that poses a threat to life or bodily function, such as organ failure, or if they're going to lose a limb. And then for our risk of complications, we have high risk of morbidity from additional diagnostic testing or treatment, such as drug therapy requiring intensive monitoring for toxicity, not therapeutic efficacy, but toxicity, or decision regarding elective major surgery with risk factors, or decision regarding emergency major surgery, decision regarding hospitalization, or decision to not resuscitate the patient or to de-escalate their care because they've got a really poor prognosis. Now, let's talk a little bit about time, because time has changed. Essentially now, if you want to bill based on time, it has to be time exactly on the date of the encounter. If you were doing prep work the day before, notes the day after, that doesn't count. It's only the day of the encounter counts if you want to bill based off of time, but there's a lot more that counts towards that time. Essentially everything except for rooming the patient and anything that you're billing out for separately, separate services, can be counted for that time. And it no longer has to be face-to-face time, and it no longer has to be 50% or more counseling and coordination of care. So it does include things like preparing to see the patient, obtaining or reviewing separately obtained history, performing a medically appropriate exam, counseling, ordering tests, meds, labs, referring and communicating with other healthcare providers, again, that you're not billing out for separately, documenting clinical information in the electronic medical records. The time for your documentation counts now if you want to bill based off of time, independently interpreting reports or results that you're not billing out for, or care coordination that you're not separately billing out for. So again, just about everything except for rooming the patient and stuff that you're not billing out separately for. And it has to be on the date of the encounter. Now you can count for stuff that's not on the date of the encounter, but only if you're going through the 2 out of the 3 categories for medical decision making and not on time. Time has to be date of the encounter. Thank you so much for just taking a couple of minutes with me to go over these essential changes. I know this wasn't everything soup to nuts. If you want that though, I do have a course you can check out and take that on demand if you are interested in more evaluation and management training. Okay, so this is post-edit Victoria here, and I made this video because I was thinking about providers who always say, oh, well, I only have a couple of minutes, just explain it to me as fast as you can. And I was convinced that I could go over the 5 levels in 5 minutes, and actually wound up being a little over 8 minutes long, and it felt super, super rushed. So can you imagine being a provider and feeling like you could learn all of that in just a matter of a few minutes? It really I mean, there was just so much that I just going through and editing, I know that I didn't go over as well or emphasize as much. And I was just, as I was going through it, thinking about all the different provider questions that I typically get when I go over some of these sections. So I think that if a provider has not at this point gone through at least 40 minutes, probably to 2 hours of evaluation and management instruction for these new guidelines, they're going to be, you know, very confused about everything that's going on. I don't know how people are going to react to this video, because I'm sure a lot of people are going to click thinking this is going to be a really good explanation of the E&M visits, and you know what? It's just, you can't do it in that short amount of time. You just can't. It was a fun experiment, but I definitely don't think I will be doing any more speed explaining medical coding videos again. I've done some pretty decent sessions where I've explained it in like an hour, and I think that's a pretty good sweet spot. So we're in the second week of January as I'm filming this, so I hope that everyone has gotten education at this point on those 2021 E&M changes. Don't worry if you do need some information. I am going to be doing a video soon that is my how to pass the CPC exam in 2021, and I'm going to go over what they test you on for the E&M visits now for those office visits in 2021. So definitely check that out if you're interested. I will see you guys in the next video. Until then, just keep on coding on.